Thank you, Dr. Theosailer. I want all the audience to be here because he's going to come right in the middle with his keynote address. And I'm sure we would have lots to hear from him. I would be showing you n number of case situations. I have a time allotted of 12 minutes. I might rush through it, so you are welcome to ask questions if there's any query at the end of it. Basically, as we stand today, what we need to know is that as far as refractive surgery is concerned, we need to have a very in-depth knowledge of the topography and the technology which coexist. And most importantly, we need to be sensitized to the needs of our patient. The points which I am going to highlight briefly is cross-linking with refractive surgery, when and why I would do it, which suspicious topographies I would not treat and which I would, when I would plan a topo-guided treatment on a normal cornea, and when I would do it on an abnormal cornea. So essentially, these are the different options wherein we combine refractive surgery in cross-linking with what we have understood over the last 2-3 years. One thing comes very clear, that in laser vision correction, there is a definite weakening of the corneal structure, more when the flaps get thicker, and it presents as regression or as iatrogenic ectasia. And we also understand, as of today, that cross-linking definitely adds to the tensile strength of the cornea and should definitely address regression and ectasia. So our concerns were about the haze and the scatter if we were to combine cross-linking with refractive surgery, or would there be a progressive flattening. But today, with the understanding which has evolved over the last few years, these are the patients with whom we would combine cross-linking with refractive surgery. I would rush through some of the examples. Essentially, a word is that we would, when we do here, we would do with Vibex Extra, wherein we combine riboflavin with methylcellulose as a vehicle instead of dextran. And because dextran, we should also know, predisposes to DLK. And this is what would be our treatment parameter in all these case scenarios. That is half what we would use in a full-blown keratoconus, just 2.7 millijoules per centimeter square. The first minute, we would just soak it with riboflavin at intervals, and then go ahead and treat the refractive error. After the full correction of the refractive error, we soak it for a minute with Vibex Extra and then expose it to UV light of 30 milliwatts per centimeter square for 90 seconds, which is how I do it in my practice, and we've had consistent, stable results. Again, there is no refractive surprise and no refractive flattening. This is one case wherein the patient had a fairly normal corneal thickness, but all the floats showed suspicion. It showed similar in the other eye to a mirror image. The Bellin again picked up some suspicious red flags. And this is a clear situation, although the corneal thickness allows, wherein I would combine it with cross-linking, and 6 months down the line, if you could see, the cornea was more stable and the purpose was served. Going on to the next case scenario, before I go on further, we would not combine it with mitomycin C when you're doing a cross-linking with surface ablation, because cross-linking itself causes apoptosis of the keratocytes in the anterior stroma, and it takes care of the haze component. Now looking at regression, wherein we would combine cross-linking, this is a patient who came in with a high hyperopia. Clearly, I would not plan to doing more than +4, even if the K values are accommodating. Here the K was quite fine for the refractive correction. Patient was very clear that he didn't want an intraocular surgery, was prepared for a residual refractive error, was there for a shorter period of time, had to come and go, was living abroad. So I went ahead and did a +6, but here again, with lot of misgivings, I did that correction, and I combined it with cross-linking, and I have been seeing him over a year now, and interestingly, it's sort of like the amount of power which I had left uncorrected was all that he had as a residual power. Is probably one of my happiest of patients. But I clearly know, as Dr. Theosailer said in his earlier talk, that the progressive flattening in a hyperopic correction seeps in after a year or more. But here we had combined it with cross-linking, and I do hope that some amount of the regression was addressed. And again, the K value after the correction was well within 48 diopters, which was acceptable. This is the other area where we would combine it with a thin cornea. Here again, the corneal thickness was about 490 odd, And the refractive correction ideally would be just about 5 or not more. And this patient again had a shallow anterior chamber, could not have gone in for an ICL. So here again cross-linking is done, but here I would prefer to create a flap, a 90 micron flap. And the only word which I want to add as far as doing this procedure is that we need to protect the flap, we need to invert it, keep it as a taco, and then do the usual procedure of soaking and the treatment after putting the flap back. And again, the refractive stability was achieved. The importance is that we need to avoid cross-linking the flap because it does not contribute to the biomechanical strength, and also we need to remember that there could be some amount of flap shrinkage, and the patient achieved plano refractive error. The topographic challenges, when would I treat? This was a patient who came in his early 40s with an epithelial ingrowth, was not exactly disturbed in his right eye, but the left eye had residual refractive error and he was fairly disturbed, and this is how his topographic picture was. But he had had an enhancement 6 years before, and with this extent of epithelial ingrowth, it has not exactly progressed to the visual axis. I would not lift this flap and treat it and make it a more bizarre situation. However, this is a guy who had a -4 refractive error, who came in for a SMILE procedure and came back in 6 weeks with a small residual refractive error. But when you looked at his clinical slit lamp photograph, you notice that he has epithelial nest right within the visual axis, and this is the ideal time to intervene. So I took him back to the theater and told him that I'm not very clear whether his residual power would be totally corrected, but he definitely needed a touch-up. It was a little difficult to get it to the incision because the flap was essentially so closely apposed, and I wasn't in a position to put a mitomycin gauze there. So I debrided the area of epithelial ingrowth and washed it with mitomycin C of 0.2% for 30 seconds and treated him with steroid drops. And interestingly, all that he had was this central haze, did not disturb him at all. He had a plano refractive error, and I believe that that was the best solution which could be offered in this kind of sitting. As far as normal corneas are concerned, if you have a topographic dilemma which you have created during the surgery, we definitely need to do a resurfacing of the cornea, try to make it as symmetrical and rotationally asymmetric. This was a patient who within 2 weeks after a microkeratome flap lift had epithelial ingrowth and a very significant residual refractive error. Primarily, we did a interface wash and mitomycin C, a debridement was done and mitomycin C was placed. The cornea cleared up, but the patient definitely needed regularization and kept on complaining about the visual deficit. You can see the area of flattening in the region of the epithelial ingrowth. So in this situation, as the Q value was within the normal limits of 0 to -1, it was 0 here. So what we did was just did a topographic regularization with the 0.5 overcorrection which you do need on a surface ablation. Her corneal topography regularized, and 6 weeks down the line, I called her again for a treatment of the refractive error, but she came back after 3 months and she only had a 0.75, so she did not need a topographic correction, a wavefront optimized treatment for the refractive error. So sometimes it makes sense to make the patient wait after the primary regularization if you're doing a 2-step procedure. This is another patient who had a primary RK and had a good life for 16 years, came back with a very significant mixed astigmatism, and definitely wanted a solution. And we all know how the hyperopic correction, how the correction progresses in an RK patient with the intermediate steepening which occurs. Her Q value was 0.9, so we needed to do a Zernicke's regularization in her case. We chose the best map which was necessary. And essentially, when you're doing a regularization and the Zernicke's polynomials, we need to add some amount of defocus or myopia to cancel the spherical aberration which has been created to make it a more aspheric cornea. It was found that we needed to add a -1.25 of defocus. To this, what is the 0.5 overcorrection for a surface ablation plus the nomogram correction. So finally, the patient needed a -2 correction, and this was how the plan was, the topographic correction, and the patient was significantly happy, although she had a residual refractive error. She came back to me after a period of 6 months, and I did a wavefront optimized treatment for this refractive correction. And after that, for the last couple of years, she's been coming and a very happy patient. So there is a need for doing a regularization in a normal cornea, which has been iatrogenically irregularized by us. Again, this was another patient who had a microkeratome procedure, had a free flap, and probably because the flap was not appropriately repositioned, treated elsewhere. And she came in, and we went ahead and did a topographic regularization. Again, here the Q value was within normal limits, so just a regularization of the cornea was done, and this is how the cornea became after the treatment. She did have a residual refractive error, and this refractive error was treated after a period of 6 weeks with a plano refraction. Now, the last area of my talk is topographic challenges which come in abnormal corneas. How does it work? Essentially, you are doing a topo-guided PRK with cross-linking. So here the way the treatment is, there is a central myopic ablation and a mid-peripheral hyperopic ablation is created, which sort of makes it a flatter and a broader cone, rather redistributing the biomechanical strain in the eye. And this, which is combined with cross-linking, stabilizes the eye so that the patient has a better visual result. It does not correct the refractive error, and at the most you could remove about 40 to 50 micron of the tissue. There are two examples where I'm showing. Patient had a full-blown keratoconus and decent amount of corneal thickness. This was a pre-op refractive error, and this was the amount of refractive error which was corrected with a central ablation of 59 micron. And here the refractive correction was done. There was no way we were touching the Q value of the eye, and the patient attained plano after the correction along with the cross-linking which was done. What we need to know here that the cross-linking is the full-time cross-linking which is done for a keratoconus patient. Again, I would do it as a simultaneous treatment, that is, do the refractive correction, the amount I want to treat to regularize the cornea to fair, decent levels. Definitely, you have to look at putting in an ICL. All these aspects come in once the topography stabilizes. And the haze is taken care of by the cross-linking, because the cross-linking causes apoptosis of the keratocytes up to 300 microns. And it does not make sense to do it sequentially, because we are not at all clear how a cross-linked cornea would behave if we were to do an ablation at a later date. This is the last example. Again, a full-blown keratoconus, and this was the amount of refractive error which was corrected, and of about 50 micron. Here again, there was a residual refractive error which remained, but the topography, as you can see, was more acceptable. And if we have counseled our patients, and when the patients come back with the treated eye, they're definitely happy patients, far more happier than our regular refractive patients, because they've gone through the period of decline in their vision. So it makes sense to do a topo-guided treatment along with cross-linking, and this would be the parameter which we would use for all our patients, 5.4 joules for irradiation time of 10 minutes with 9 milliwatts per centimeter square. So essentially, I would like to conclude that there is no tailor-made situation which would fit all our refractive patients. In some, it has to be a one-step treatment or a two-step treatment. We have to be very conservative not to use more than 40 to 50 micron of tissue for regularization, but definitely try to do something to improve his best corrected visual acuity. Thank you.